Welcome back to the course as we begin our third section, which introduces the core fundamentals of procedure and service coding. Now that you understand how to code the diagnosis, it is time to learn how to code the actual work the physician performed using the CPT and HCPCS Level II code sets. This knowledge is incredibly important because these codes directly determine how much the medical practice will be paid for their services. I am excited to guide you through this material, as mastering these coding manuals will give you the confidence to tackle any clinical scenario on your exam. In the outpatient setting, procedural coding is divided into two distinct levels that work together on the medical claim. Level 1 is the current procedural terminology, commonly known as CAPTAN, which is owned and maintained by the American Medical Association. Level 2 is the Healthcare Common Procedure Coding System, known as HCPCS, which is managed by the Centers for Medicare and Medicaid Services. Together, these two systems ensure that every single surgery, office visit, medical device, and drug injection can be accurately reported to insurance companies for payment. The CPT code set is the foundation of physician billing and consists primarily of 5-digit numeric codes. The main body of the CAPTAN manual is divided into 6 major sections, which are evaluation and management, anesthesia, surgery, radiology, pathology and laboratory, and medicine. When searching for a code, you will follow a similar process to diagnostic coding by first looking up the procedure in the alphabetical index at the back of the book. Once you find a suggested code range, you must turn to the main tabular section to read the full description and verify your final choice. As you navigate the CAPTAN manual, you will notice various symbols printed next to the codes. And knowing what these symbols mean is crucial for the exam. A solid black bullet point next to a code indicates that it is a brand new code added to the manual this year. A solid black triangle means the code's description has been revised or significantly changed since the last edition. Recognizing these symbols helps you quickly identify recent updates, ensuring you do not apply outdated rules to new clinical procedures. One of the most important symbols is the plus sign, which designates an add-on code. Add-on codes represent supplementary procedures that are performed in addition to the primary service by the same physician. By definition, an add-on code can never be billed by itself as a standalone procedure, and it must always be sequenced on the claim directly underneath its associated primary code. Using an add-on code as a primary service is a major compliance error that will result in an immediate claim denial and a lost point on your certification test. Beyond the main 6 sections, the CPT manual also contains Category 2 and Category 3 codes, which serve entirely different purposes. Category 2 codes are optional, alphanumeric tracking codes used for performance measurement and quality reporting, and they never generate any direct financial payment. Category 3 codes are temporary codes used to track emerging technologies, brand new services, and experimental procedures that have not yet been approved for a permanent code. If a Category 3 code exists for a specific new procedure, the official guidelines mandate that you must use it instead of an unlisted Category I code. The most frequently used section in the entire CPT manual is evaluation and management, commonly referred to as E.M coding. E M codes represent the cognitive work a physician performs during an office visit, hospital consultation, or emergency department encounter. These codes are graded on a scale of complexity, with higher numbers indicating a more difficult patient encounter that requires more of the doctor's time and mental effort. Because these codes are used for almost every patient visit, mastering the E/M rules is an absolute requirement for passing the certification exam. Under the modernized E/M guidelines, you will select the appropriate level of office visit based entirely on one of two factors, either the total time spent on the date of the encounter, or the level of medical decision-making. The history and physical examination are no longer used to determine the final code level, although they must still be documented if clinically appropriate. This simplified system allows physicians to focus more on patient care and less on counting bullet points in their clinical notes. For the exam, you must be comfortable leveling a visit using either time or medical decision-making depending on what the documentation provides. When using time to select an E/M code, you must count the total time the provider personally spent on patient care during the exact calendar date of the encounter. This includes both face-to-face time spent in the exam room and non-face-to-face time spent reviewing records, ordering tests, or writing the clinical note later that day. You cannot include time spent by the clinical staff, such as a nurse taking vital signs, because the physician did not perform that work. If the provider's documented total time meets the threshold required by a specific CPT code, you can select that code directly. If the provider does not document their total time, you must determine the E/M level based on the complexity of medical decision-making. Medical decision-making, or MDM, measures the mental effort required to diagnose and treat the patient. The MDM level is calculated by scoring three separate elements: the number and complexity of problems addressed, the amount and complexity of data reviewed, and the risk of complications or morbidity related to patient management. To qualify for a specific level of MDM, the documentation must meet or exceed the requirements for at least two of these three elements. Let us break down those three elements, starting with the number and complexity of problems addressed. This element looks at how sick the patient is and how many separate illnesses the provider is actively managing during the visit. A minor problem that will heal on its own, like a simple cold, scores very low. However, a severe exacerbation of a chronic illness, or a brand new acute problem that threatens the patient's life, will score much higher. You must evaluate the physician's assessment and plan to determine exactly how many conditions were actually treated that day. The second element of MDM is the amount and complexity of data reviewed and analyzed. This section requires you to count every single medical record, laboratory test, and radiology image the physician had to review to figure out what was wrong with the patient. It also includes the effort of ordering new tests or requesting consultations from other medical specialists. The more complex the diagnostic puzzle, the more data the physician must review, which naturally drives the E/M code to a higher level. The final element of MDM is the risk of complications, morbidity, or mortality related to patient management. This evaluates the danger involved in the treatment plan the physician has recommended. Recommending rest and over-the-counter ibuprofen carries a very low risk to the patient. Conversely, prescribing powerful medications with severe side effects, or deciding to perform an emergency major surgery, carries a high risk. The exam will frequently test your ability to correctly identify the risk level based on the specific treatments listed in the provider's plan. Now let us shift our focus to the HCPCS Level II code set, which fills the gaps left by the CPT manual. While CPT covers what the doctor did, HCPCS covers the physical items and supplies the doctor used. HCPCS codes are alphanumeric, meaning they always start with a single letter followed by 4 numbers. These codes represent durable medical equipment, prosthetic devices, ambulance transport, and most importantly for the outpatient setting, injectable drugs. The J codes within the HCPCS manual are highly tested on the certification exam because they are used to bill for medications administered directly in the clinic. If a patient comes in for a vitamin B12 shot, you will use a CPT code for the physical act of injecting the needle. But you must use a J code to bill for the actual liquid vitamin itself. When coding drugs, you must pay extreme attention to the dosage listed in the code description. If the doctor injects 100 milligrams, but the J code description is per 50 milligrams, you will need to bill 2 units of that specific code. HCPCS also contains temporary codes, such as G codes and C codes, which represent specific services required by Medicare and other government payers. G codes often report specialized preventive services, telehealth encounters, or quality tracking measures that do not have a perfect match in the Captain manual. C codes are temporary codes used exclusively for the hospital outpatient prospective payment system, particularly for new medical devices and surgical implants. While taking the exam, you must always read the prompt carefully to see if the patient is covered by Medicare, as this often dictates the use of a G code. You will inevitably encounter situations where both a CPT code and a HCPCS Level II code exist for the exact same medical service. When this conflict occurs, your code selection depends entirely on the rules of the specific insurance payer. As a general rule, Medicare and Medicaid will almost always require the HCPCS Level II code, while commercial private insurances usually prefer the Captain code. On your certification exam, the test question will provide enough context about the payer to help you make the correct choice between the 2 manuals. To successfully extract procedure codes, you must develop the habit of reading the clinical note from the bottom up, focusing heavily on the final treatment plan. Unlike diagnostic coding, which relies on the assessment, procedural coding requires concrete proof that an action was physically completed. You must find documentation detailing the exact technique used, the specific equipment involved, and the precise anatomical location where the service was provided. If the provider states they plan to perform a procedure, but there is no documentation proving they actually finished it, you cannot legally bill for it. One common pitfall for new coders is unbundling, which means billing multiple separate codes for components that are already included in one comprehensive main procedure code. The CPT and HCPCS systems are designed so that minor Incidental tasks are naturally bundled into the larger surgical package. For example, the act of making the surgical incision and closing the wound with stitches is always bundled into the main surgery code and should never be billed separately. Recognizing what is bundled versus what is separately reportable is a key skill you will continue to develop throughout this course. Congratulations on completing Section 3 and expanding your knowledge into the vast world of procedure and service coding. You have taken a major step forward by learning the structures of CAPTAIN, the new E.M. guidelines, and the vital role of HCPCS Level II codes. I strongly encourage you to complete the attached practice test right now while these concepts are fresh in your mind. Using these practice questions will solidify your understanding, improve your retention, and build the critical thinking skills needed for exam readiness. You are progressing wonderfully, and I look forward to seeing you in the next section where we will tackle advanced CPT coding and modifiers.